Okay, good mid-morning. It's almost afternoon to everyone. First, I want to thank Trisha and the entire staff at OCHN for having me. It always makes me feel good when I'm invited back. So I thank you for that. And just to kind of level set, I want us to have an engaging conversation, so I'm not going to talk at you too much. I am terrible at following the chat room, so please put any questions, comments, or concerns in the chat, and Trisha will help me address those at the end because I'm not very good at multitasking when I'm doing these things. Um, and so I will get started. Oh, I guess my last disclaimer is many of you probably know me, and I say that with humility. But I'm not a doctor. I'm not a psychiatrist, psychologist. I'm an activist and mental health and suicide prevention advocate. And I'm really pleased to be here. So again, for those who may not know me, I'm Kevin Fischer. I'm the executive director for NAMI Michigan. I wear many hats. I'm also the CEO of the Dominique Fisher Memorial Foundation and Everybody versus Stigma. And I know many of you are wearing or have been wearing our Everybody versus Stigma apparel. I've seen many pictures. I still like to see them come in. And thank you so much for that, because I look at this as we're all in this together. I still very much consider stigma to be the leading barrier that prevents people from seeking the help that they need, and making their way to your doors, quite frankly, because that's the first step. So I came to this work, again, for those of you who don't know me, I'm a retired businessman. I came to this work in late 2010, early 2011. After my oldest son, Dominique, had been diagnosed with serious mental illness in 2007. He was diagnosed bipolar and schizophrenia. And my family learned very quickly that we knew nothing about mental illness. We knew nothing about the behavioral health care system. We knew nothing about treatment plans or, what his life was going to look like going forward. And on this journey, we've learned about the stigma, quite frankly, how stigma affects mental illness, and those seeking care in various cultures and communities. And that's what we're going to talk a little bit about today. But unfortunately, that journey for us came to an end on June 27th of 2010 when we lost Dominique to suicide. So I came to NAMI looking for help for myself, trying to understand, frankly, what I missed, what I didn't know about mental illness, all the things that I talked about before, and really trying to learn how to manage the grief that came along with losing my son. So I'm very passionate about this work. I am very grateful for the opportunity and the privilege to be able to work with persons who receive services, and all of you who are professionals, volunteers that are in the behavioral health care space, because it is truly, I think, a thankless job and career, and I don't think people really understand and respect the passion that you put into the work every day. So I thank you for that. And I'll move forward if we can go to the next slide. So I'm sure everybody's familiar with NAMI, so I'm not going to dwell on this long, but NAMI is the National Alliance on Mental Illness. We are the nation's largest grassroots mental health organization that's purely dedicated to building better lives for the millions of Americans affected by mental illness, not just those who are living with mental health diagnoses, but for their families, caregivers, and literally the community at large, because we feel that directly or indirectly, everybody's affected by mental illness. What started in 1979 was a small group of families. It was 6 families gathered around a table in Minnesota, has blossomed into the nation's largest grassroots mental health organization. We have over 650 affiliates nationwide. The group of mothers who started this organization, we still affectionately refer to as the NAMI Mommies. And I am incredibly grateful to them for starting this organization, because they were mothers who decided that their children who live with mental health diagnoses weren't getting the treatment or didn't have access to treatment that they thought necessary So that was the origin of this organization. We can go to the next slide. NAMI focuses in 4 general areas. We listen, we operate helplines at our national office in Arlington, Virginia, and at our local affiliates across the country. So we take hundreds of thousands of calls every day or every year to help, one, connect families with behavioral healthcare resources like OCHN and all of the providers that support. We help people just kind of understand, a mental illness diagnosis is very traumatic. And we help people who find themselves in the situation I found myself in, just didn't understand, didn't know where to go, didn't know how to start. We educate, we offer education and support programs at no cost to participants in the communities we serve. We advocate for policy in all 50 states individually and, of course, nationally. And I have the privilege of working with Dana and Christine and so many other people on your team here in the state of Michigan to improve and increase access to behavioral health care resources. And we lead through public forums, like participating in events like this Lunch and Learn, the NAMI Walks, the state conferences, and all of the other events that we support, ultimately to increase awareness and eliminate the stigma. So we can go to the next slide. And so we're going to talk today about mental illness. One of the facts that I know we all know, but I think is worth repeating, is that mental illness simply does not discriminate, not by race, religion, socioeconomic status, doesn't care if you're Democrat or Republican, doesn't care how you identify, your sexuality, or by location, doesn't care if you're urban, suburban, and rural. And we know in Michigan, there is a lot of disparity in access to care, literally by location. We can go to the next slide. The other thing that we know is that stigma does not discriminate. Like mental illness, it does not discriminate. It affects us all, but it does vary by community and culture. And that's what we're going to talk a little bit about today. So we can go to the next. We know that 75% of people with mental health conditions tell us that they've experienced stigma. I personally, and NAMI as an organization, believe stigma is the leading barrier to the early diagnosis and treatment that leads to better outcomes. I had the opportunity to spend some time with Senator Stabenow a few months ago as she was introducing CCBHCs here in the area. And we were talking about the importance of access to high quality behavioral health care. But one of the things that we kind of bantered back and forth about, and it's something we both agree on, is while that is a significant issue, I still think stigma is the leading issue. We have to overcome stigma. If we don't get past the making people feel weak or less than, or that it's their fault that they're living with a mental illness diagnosis, they simply won't take the first step to seek the help that they need. They'll never show up. They'll never pick up the phone and call OCHN or any providers and say, hey, I need help. So we have to get past stigma. Then there's access and understanding. Well, let me back up. The availability of and then access to high quality behavioral health care. That's where we have to go. We can go to the next slide. So what's behavioral health equity? Behavioral health equity is the right to access quality health care for all populations, regardless of the individual's race, ethnicity, gender, socioeconomic status, sexual orientation, or geographic location. This includes access to prevention, treatment, and recovery services for mental health and substance use disorders. And that's the definition provided by SAMHSA. And, you know, interestingly, as I cover the state, whether I'm up north, whether I'm here in Southeast Michigan or west side of the state, I hear concerns from citizens that they don't feel like they have access, or they don't have enough access, or and more importantly, they're not even aware of what behavioral health resources are available to them. And it's kind of a dirty word, I guess. I come from a sales and marketing background, and I believe in the power of marketing. And the more I hear people's concerns, the more I think about the fact that, unfortunately, we need, as a community, we need to market better. We need to raise awareness of what behavioral health resources are available and how to access them. Because for people who are not in the system already, the average Michigan citizen, and I would say American citizen, just really isn't aware of what resources are available to them. And then the fact that those resources tend to be more scarce in communities of color. And we can go to the next slide, please. So one of the things that came out, I guess I'll say one of the positives that came out in the last year and a half, frankly, since the George Floyd murder, is nationally organizations, and even I've heard the president and even Governor Whitmer say, racism is a public health crisis. And in my lifetime, until last year, I'd not heard that said. I'd not heard it articulated that way. I'd not heard us begin to embrace that reality. And what we have to understand is that while there's much we need to do to address racism in the country, we cannot forget the importance of mental health as we do so, because the effects of racism and racial trauma on mental health is real and cannot be ignored. The disparity in access to mental health care in communities of color cannot be ignored. And the inequality and lack of cultural competency in mental health treatment cannot be ignored. And we're going to talk a little more about this today. And the statements that I just read are quotes from NAMI's National CEO and Executive Director, Dan Gillison. And Dan had literally just come on in this role at NAMI literally just a couple months before the George Floyd situation. So I was really proud. He was the first national leader I heard make that statement, and then there were many others and corporations that followed. So we can go on to the next slide, please.
Kevin, do you want to take questions throughout, or do you want me to save them for the end?
Either or. I can take them throughout.
All right. One, I love that you have this slide. We were lucky enough to have a presenter in earlier this year with the exact title of this slide as a training, so we were able to offer that to our network. Sherry has a question in the chat. Do you think that the adoption of 988 will help decrease stigma?
Sherry, that's a great question, because initially I thought 988 was a great breakthrough. But as I talk to more people, honestly, I have some concerns. And even particularly when I talk to folks in law enforcement and even some folks at the legislature, that even though it's a good move to go from an 800 number to a 988 number, there's still going to be some stigma attached to 988 versus 911. And we need to understand, it took more than a decade for people to adopt to 911. It's going to take quite a while for us to make that cultural shift from 911 and discerning, am I calling 911 for law enforcement response, or am I calling 988 for behavioral health care response? And the problem, one of the potential problems, I think there's the potential to continue to stigmatize persons experiencing mental health crises. But the other concern that I have is, will people know when to choose one or the other? Because sometimes, and there was a situation actually we talked about on a conference call on the Governor's Mental Health Diversion Council yesterday. Some of you may be aware there was a situation in Ann Arbor recently where there was a barricaded gunman situation. But what wasn't covered on the news was that that man was known to be a familiar face to law enforcement of someone who experiences mental health crisis. But law enforcement didn't want to, frankly, my understanding was refuse to transport him to a crisis center because they didn't have a signed court order from a judge. So that situation went from, we could have been proactive and taken someone who we knew needed behavioral health care help to a crisis center. Because they ignored it and delayed and responded, they ended up calling a SWAT team, and it turned into a barricaded gunman situation. And that's never what our intent is. And I use that as an example because, again, there's so much confusion already when situations arrive. I don't know how quickly we're going to be able to adapt to 988 in the most efficient manner. I hope that answers the question. I think it's a good move, but I have some concerns.
Great, thank you, Kevin.
Yeah.
And we had another question about explaining what 988 is. I did put it in the chat for people who maybe don't know that 988 is a new 3-digit phone number for people to call if they are in crisis to connect with suicide and mental health counselors, very similar to 911, which Kevin was saying, but also sounds, like that city may need some more CIT training, Kevin.
Exactly. Well, and interestingly, and just for the folks who are unaware, 988 will go into effect July of 2022. That's when the switch is supposed to be made officially. And here's, I have a bit of a biased concern even about the suicide prevention hotline, and I hope I communicate this clearly and it doesn't come across offensive to anyone. And I was having this conversation with a family in Portland, Michigan yesterday who unfortunately lost their son to suicide. We are a reactive society when it comes to mental illness, mental health care, and our response to it. And that proves to be deadly far too often. And we know that mental illness is a medical diagnosis and we need to treat it as such. And for example, addressing someone's mental health issues early on is like catching cancer. Do you catch cancer or do you have a better survival rate if you catch someone at stage 1 or stage 4? The earlier we intervene, the more likely a better outcome. So going back to that situation in Ann Arbor for a moment, it's not just CIT, and we can talk a little bit about that as well, but it's also the judicial system and the community as a whole embracing and again being aware of and knowing how to access behavioral health care resources. Because the fact of the matter is there's laws on the books that address that say that a peace officer does not need a signed court order to transport someone if they reasonably believe that they are experiencing a behavioral health care crisis. But sometimes it's the knowledge of and understanding of the laws or the tools that are available. The other part of it is the willingness, quite frankly, because I still go into communities that are not interested in making use of CIT or any other crisis response models. I've spoken to law enforcement officials who refer to themselves as hook 'em and book 'em chiefs or sheriffs and say, hey, I don't have time for all that mental health mumbo jumbo. They haven't, I don't want to say bought into it, but they're not up to speed yet. And some we're going to have to drag kicking and screaming. The other part of it is in the judicial system, there are judges in communities that either aren't aware of or choose not to make use of tools available to them like assisted outpatient treatment or what we call Kevin's Law in the state of Michigan. I received calls from a number of communities that say, yes, we are aware of it. We presented this information to the probate judge in my community, but they have said, we're not offering that here. And the fact of the matter is, it's not an optional program. assisted outpatient treatment is law. It's been law in Michigan since 2004, and everybody should have access to it. But that's another story. Any other questions, or you want to move on?
There was one in the chat from Rachel about, is there a program to educate younger people on these tools?
Absolutely, and Rachel, great question. So there are many organizations, and I'm sure Oakland does so, that we have programs in school. NAMI, and I'll speak to the ones I know best. NAMI has a program called Ending the Silence, and there's actually 3 variations of the Ending the Silence presentation. One is an anti-stigma presentation for students in junior and senior high school, to help raise awareness and eliminate the stigma and make them aware of resources that are available. The second is for teaching professionals, where we'll go in on an in-service day and do a 90 minute to a 2-hour presentation to teaching professionals, not just teachers, counselors, administrators, but for the lunch lady, for the janitors, for the school bus drivers, anybody who comes into contact with our young people, because the fact is, most people in those school settings, and I'll continue to refer to them as teaching professionals, they tend to interact more one-on-one with our children than we do, because they have access to them during the day. We see them in the morning, we get them off to school, and then we see them in the evening when we're rushing around trying to prepare dinner and get them ready for bed and all that stuff for the next day. But kids tell me that they have relationships with their favorite custodian in the school, or lunch lady, or hall monitor, or whatever it may be. And sometimes those are the best people to notice changes in our children. But one of the things, Rachel, young people have told me is we're missing the mark as adults, because we think we've created all of these programs and these resources, but they're not resonating with them. And so I did a lunch and learn with students from Plymouth Canton High School back in May during Mental Health Awareness Month, and they told me 2 things. They said, 1, we want to know what resources are available to us in our immediate community. Don't keep giving us 800 numbers. If I want to be able to walk downtown to a behavioral health provider, whether it's a social worker or someone in private practice, they want to know about those resources. The other thing they tell us is, and I've long suspected this, but I really thank them for validating it for me. Us parents are more the perpetuators of stigma than our kids are. These kids are open and honest and really willing to talk about their experience with behavioral health related issues. They will tell you that they're feeling depressed, or they're living with anxiety, or they have an eating disorder. They will tell you that they've experienced suicidal ideation. They'll present it in poems, spoken word, they're writing songs. They'll tell you that, yes, I take medication. They're proud to say, yeah, I have a therapist. I was with MDHHS Director Hertel a couple of weeks ago on a panel, and she said publicly, she said, all of my kids have their own therapist, and they're proud of it. And so kids aren't afraid of it. It's us parents who don't want our coworkers, our friends, the people we sit next to at church to know that we or somebody in our family is experiencing a mental health crisis. And frankly, we need to get over ourselves because the consequences are deadly. So we're trying to do a better job at making kids, or I should say young people, aware. I'm involved in a number of initiatives that include young people in the planning of programming and helping us understand how to better connect with them and what resonates with them. So again, Rachel, great question. I hope we all continue to listen to young people, because they're the change that we seek anyway. They're going to carry this ball into the future for us. Any others, Trish?
Nope, that was it. I did put in the links to Ending Silence and then the NAMI programs as well in the chat if anyone wants to check those out.
Thank you so much. And we'll keep going, but please don't hesitate to stop me. So what happens at the intersection of mental health and one's experience as one experiences members in not only Black communities, but all communities of colors. The experience of being Black in America varies tremendously. There are shared cultural factors that play a role in helping define mental health and supporting well-being, resiliency, and healing. I'll use myself as an example really quickly. And we talk about the variance in stigma or the experience of living with mental illness in the African American community. I am very open talking about my son's experience, his diagnosis, his subsequent death by suicide, and even my own experiencing suicidal ideation. And I still very much live with depression. I've not recovered from losing my son. It was 11 years ago. I still struggle with depression from time to time. And it's interesting because in many communities of color, there are still people who believe, well, Black people don't die by suicide. Well, nothing could be further from the truth. One, I experienced it firsthand, but the CDC started reporting, I believe in 2017 or 2018, that the suicide rate among African American boys between the ages of, I'm going to forget the number now, I think it's 7 and 14, is twice what it is for Caucasian boys. So, this myth that Black folks don't die by suicide we need to get over. It's also really interesting. I was with my friends down in Detroit, Wayne, a few months ago as they were facing some community resistance to establishing a crisis center in downtown Detroit. And on one hand, I'm just going to be blunt and frank about it. Again, I hope I don't offend anybody, but I consider this kind of a coffee room conversation. In the African American community, we complain about what we don't have. We complain about not having resources. But then when we have the opportunity to get resources, we say we don't want it or not in my neighborhood. We can't have it both ways. We can't complain and say, I don't want to have to drive my loved one to Pontiac, to Common Ground, or out here to Livonia, to Higueras Cope. We complain about having to do that, but then when we have an opportunity to have our own crisis center in our own community, we say, well, we don't want it here. We can't have ways. We can't be hypocritical about it. So that's where I'm at. And it's also really interesting that, in our communities of color, as I mentioned before, stigma varies in how we deal with mental illness and suicide and substance use, and all those things vary because so many people, for example, want to pray it away. And we have to be very clear. We're starting to see people in the faith community come around, but just as God provided us, and I believe in I call it prayer plus. Just as God gave us cardiologists and oncologists, God gave us social workers, psychologists, and psychiatrists as well. And we have to make use of the tools that are available to us. If there are no questions, we can go to the next slide. Part of that shared experience in facing racism, discrimination, and inequality this significantly affects a person's mental health. Being treated or perceived as less than because of the color of your skin can be stressful and even traumatizing. Additionally, members of the Black community face structural challenges accessing care and treatment that they need. I tell people, even though my son died by suicide, stigma killed my son. Dominique was doing very well in his treatment until he arrived at the conclusion that he didn't want his friends to know. And part of the way he arrived at that is because, quite honestly, we had family and friends who were telling him, there's nothing wrong with you. You just need to focus harder. You need to pull yourself up by your bootstraps. They would tell his mom and I, you need to take that boy to church. You need to pray. You need to take him to see the pastor. All of that's great, but Dominique needed professional care. And when he stopped making use of the tools that were available to him, he ended up self-medicating, and we ended up losing him. So despite those needs, only 1 in 3 Black adults who need mental health care receive it. And that's because we're less likely to receive guideline and consistent care. We're less frequently included in research. We're more likely to use the emergency rooms or primary care. You know, think about what's going on with the COVID vaccine right now. And I'm not judging anybody. I wish and I encourage people to be educated about the vaccine, and I encourage people to get it. But in the African American community, there are so many of us who are resistant to being vaccinated because of our mistrust in the healthcare system, because of things that have happened in the past, you know, because of the experiments and Mrs. Everett's boys and all of that. But that's not an apples to apples comparison. And we have to educate ourselves, and we have to move past some of these self-imposed stigmas in our communities of color. And that comes through education. We can go to the next slide. Interestingly, while the rates of mental illness in African Americans are very similar to those in the general population, there are disparities that exist in regard to mental health care services. African Americans often receive poor quality of care and lack access to culturally competent care. Compared to non-Hispanic whites, African Americans with any mental illness has lower rates of any mental health service use, including prescription medication, outpatient services, but higher rates of inpatient services. And we have higher rates of in-person services because, you know, we end up at the emergency room, and that's the primary source of behavioral health care for us outside of the jails, because we all know the Wayne County Jail is the largest mental health treatment facility in the state of Michigan. And that's not a dig at Michigan, because if you take a look, you'll know that in Ohio, it's the Cuyahoga County Jail, and in Illinois, it's the Cook County Jail, and in California, it's the Los Angeles County Jail, and so on and so on. We have to stop using the emergency rooms as our primary source of behavioral health care. And then this issue of culturally competent care, and I'm going to address this a little later in my presentation, but I want to put a pin in it and say this, because I often receive requests from people in African American, Latino, Hispanic, Arab American communities. I want a provider who looks like me. You know, can you find me an African American male psychiatrist? While I understand that, I get it, but I don't want that to be the barrier that stops us from seeking care, because even though culturally competent care is a real issue, it's not impossible. It's not that there aren't culturally competent providers that are of other races, if you want to call it that. When I was receiving treatment, and I never thought about it, quite frankly, the first time I saw a therapist, he was a middle-aged white man, and the care that I received to him, I have absolutely no complaints about. He opened my eyes and helped me look at myself and look at self-care in a way that I never thought of, that I didn't even think men, let alone African-American men, were supposed to even think. So skin color, all of that should not be the determining factor. It is a factor. It is one that we need to take very seriously, but I don't want that to stop people from seeking the help that they need. So I wanted to put that in there. We can go to the next slide. I talked about this a little bit before, but there are critical issues that face communities of color in accessing care: less access to treatment, less likely to receive a higher quality of care, lower insurance rates. You know, OCHN is a CCBHC, or Certified Community Behavioral Health Care Center. We have, I believe, 34 in the state of Michigan right now that will provide treatment to anyone who comes in their door, regardless of severity of diagnosis, regardless of insurance status, and regardless of ability to pay. Unfortunately, again, most citizens are unaware that that exists or how to access that. So we have to do a better job of educating the community. We know there are higher levels of stigma, and it varies by community and culture. I've learned so much in the last 8 years about the variance in stigma in different communities, whether it's Asian American community, LGBTQ community, the Latino community, the Arab American community. All of that is something that we can't ignore. There's no one size fits all, and we can't treat everybody the same when they come to our door, through our doors. We can't ignore that their culture and community affects how we treat them and how they perceive to be treated. We can go to the next slide, please. I think the numbers that I saw for 2020, which were updated, said on average in the general population, about 45% of adults living with mental illness received care in 2020. But we also know that there has been a rash of attacks on Asian Americans. Well, Asian Americans only about 23% of that population receive mental health treatment. African American is still only around 33%. Non-Hispanic, mixed race, 43%, and Hispanic or Latino around 33-34%. So, and then I learned just recently that there's not even good data available on the Arab American community. And of course, here in Michigan, well, in the United States, Dearborn is the largest population of Arab Americans. And the stigma in their community is much different than stigma in other communities. We had the opportunity to have an imam speak at the NAMI conference several years ago, and he explained to me that they knew it was an issue in the community. They literally had people in their community who wanted treatment and who were of Muslim faith. They would come to the mosque, but they would come through the back door. And he said once it became known that they were providing services and welcoming people in their community who live with mental health diagnosis, he said they had more people coming through the back door than through the front door. And that tells you the need in the community, but that also tells you the stigma in the community as well. So once people understand, once we kind of just eliminate that barrier or stigma and let people know that we're here for them, they will reach out, they'll seek the help that they need. We can go to the next. Obviously, and I'm sure you all know, suicide is the second leading cause of death for young people between the age of 10 and 34 in the United States. It's the 10th leading cause of death overall. But what we also have learned is since 1999, the rate of suicide in the general population has increased by 35%. But in the African American population, it's increased by 78%. So in communities of color, we have to do a better job at eliminating the stigma. Forgive me for keep going back to that word, but that's just where it is for me. And making people aware of what resources are available and how to access them. You know that typically we only get one shot when people are willing to seek help. If it's difficult for us to connect them with a provider, if we say, well, it's going to be a couple weeks before we can get you an appointment, it is unlikely that they're going to come back. we have to be there and ready. When they're ready, we have to be ready with resources. 46% of people who died by suicide had a mental health diagnosis or condition. 90% of people who died by suicide show symptoms of mental health condition, according to interviews with families, friends, and medical professionals, which we call a psychological autopsy. Just think about that. We will lose about 50,000 people to suicide in the United States this year. If we can save 90%, now I'm a public school product, but that's 45,000 lives we could potentially save if we are proactive and preventative, eliminate the stigma, and get people the help that they need. I like those odds. I like those numbers. We also know that people in the LGBTQ community are four times more likely to attempt suicide. Transgender adults are nearly 12 times more likely to attempt suicide. And male versus female, almost 80% of deaths by suicide in the United States are by men, because men tend to use more lethal means. But women are catching up. That gap is closing. So we cannot ignore, especially teenage young ladies. That gap is closing and we can't ignore that. Were there some questions? I saw a couple things pop up in the chat, Trish, or do you want to keep going and catch them at the end?
Yeah, Cheryl left a comment just that you inspire her by using tragedy to educate. And then Lois has a comment as well. So Lois, do you want to unmute and talk about your comment in the chat? I think you're muted.
Okay. Yeah, I wasn't sure that I wanted to be known, but I guess it doesn't matter. I know there's a lot of people where I work, and they probably don't know this about me. But I responded in the chat that if I could be blunt, I know a lot of your stigma and public health crisis is based on African Americans and other less known cultures. But what I wrote, I'll just read it, saying, if I may be blunt, Caucasians suffer from discrimination and depression, and less than complexes also. I can attest to it because growing up, I faced a lot of stigma and discrimination with regards to being fat and not pretty and not looking like a cheerleader or the king queen of the class. And I suffered drastically from depression and withdrawal, but I did not seek help, but have suffered from inferiority complexes. And I realized that color and the LGBTQ and other cultures are the hot topics for now, but I just feel like some of the mental health and suicide prevention, it should be for all communities, not just based on the Black community or the LGBTQ or Asian communities. It should be all communities of all colors, all races, all creeds. And I just wrote that based on what I've been hearing you say.
And Lois, that's fair enough. First of all, I appreciate you making the comment and being willing to have this conversation. I think early on in my presentation, I said that stigma and mental illness affects everyone. And yes, to your point, The focus on this particular presentation is on diversity, equity, inclusion, but I don't exclude anyone. And I will be very honest with you, you know, being an African American head of an organization like NAMI, when I have often been criticized in communities of color for not being more specific and addressing issues in communities of color. I'll be very blunt and simplify it by saying this. As an individual and in my responsibility as the executive director for NAMI, I represent all people. I was with a family in Portland, I mentioned yesterday. It's the first time I'd ever been to Portland, Michigan. I didn't know where I was going. But you know, I was having a conversation with this family, and quite frankly, it was a white family. And I was listening to, I asked the mom who had lost her son, I said, tell me about your son. And as she was telling me about her son, John, I was taking mental notes on all the similarities that her son was diagnosed with schizophrenia and her son died by suicide. And part of the journey, her son stopped taking his prescription medication and started self-medicating with alcohol and drugs and all of those things. And we had this moment where it was like, we're very similar. You know, we look very differently. Frankly, I don't think when I got out of my car, I don't think I was who they expected because they never met me before. We arranged this meeting through my office. But I say all that to say, you know, the conversation I had with this mother is, I'm not in the judging business. I am in the business of helping everyone. And as an individual and as the director for NAMI Michigan, I am responsible and I am privileged to help and address everybody in every community. And I learn every time I go to a different community, I learn something differently. And it is in Caucasian communities, it's in American Indian communities, it's in Muslim, Hindu communities, all of that. So please know that I don't leave anybody out. But I thank you. I sincerely thank you for putting the notes in the chat and being willing to come on camera and have this conversation.
Thank you. It just sort of hit me. And like I said, I don't think anybody at CHN really knows that part of me. I'm much older and got a much different attitude of judge me if you will, I don't care. Now, but it is something that, you know, and I realize that you know, the poverty level and the races are a higher number of inferiority complexes and the health crisis, and but I just want to make sure that people understand that, you know, Caucasians suffer too, and in their own worlds. And thank you for listening.
Oh, no, you're very welcome. And I'll say this before we move on, you know, the focus is on communities of color now, because we're finally recognizing the disparities in access and outcomes and all of that. So again, I absolutely understand where you're coming from. I'm glad there's a focus and trying to make sure that every community and every culture has access to and gets the help that they need. Everyone. And I won't be happy until we do that.
Thank you.
Yeah. Any others, Trish, or you want to go to the next slide?
I think just some comments in the chat, but we can move to the next slide.
Okay. You know, I found this definition of health equity, advancing health equity on the SAMHSA website as well. Advancing health equity involves, and this, Lois, goes to exactly what you and I were just talking about, ensuring that everyone has fair and just opportunity to be as healthy as possible. This applies to behavioral health care in conjunction with the quality of services. This involves addressing social determinants such as employment, housing, and stability, insurance status, proximity to services, culturally responsive care, all which can affect and impact behavioral health outcomes. We live, unfortunately, in an incredibly polarized society now, whether it's politically, whether it's racial, whether it's sexual identity or orientation. I was listening to the radio yesterday, and I heard a commentary where a person was just giving his opinion that I agree with. He said, we need to move back toward the middle. We're way too, we got people way too far to the left and way too far to the right. And we need to get back to the middle where we can address the issues and concerns of everybody and make sure everyone has fair, just, equitable access to treatment and care. We can go to the next. Some barriers to care. Physician-patient communication differs for African Americans and whites. One study found that physicians were 23% more verbally dominant and engaged in 33% less patient-centered communications when dealing with African Americans versus white patients. This has to do with cultural competency and disparity in care and outcomes. It's hard enough for anyone to seek behavioral health care help, to accept the diagnoses and go to the doctor for the first time and say, hey, I need help. It's hard for everybody. But when you go and you feel like you're being talked at instead of talked to, and when the doctor is, or the provider is telling you what your future should look like rather than getting your input, that is crushing. I remember my son coming from the doctor one day. His mom took him to a doctor's appointment, and I'm not throwing mom under the bus at all, but he was really upset. And when I asked him why, he said, I hate when people talk about me like I'm not in the room and that I'm less intelligent. And he was like, they were talking at me. Nobody asked for my input. My son was 23 years old. And he brought that to my attention. And I remember he and I having this exchange where I said, you know what? I will not disrespect you when I take you to the doctor. I said, the caveat for me was you have to be honest and tell the doctor the truth, because my son would sometimes tell the doctor that, yes, I'm taking my medication as prescribed. And like, no, you're not. And let's be honest about that. But I said, I won't talk at you. I will talk to you. And then the reality, and here's the reality, these are some of the disparities we live with. The reality is that Black people with mental health conditions, particularly schizophrenia and bipolar disorder and other psychosis, are more likely to be incarcerated than people of other colors. I walked all 3 Wayne County jails with the chief of jails, Robert Dunlap, 2018, I think it was, 2018 or 2019. The Wayne County jails were filled with people who looked like me, quite frankly. And they're not getting the treatment that they need in jail. You know, I'm not going to go too far back in the history, but the Kennedy Commission back in 1963 determined people recovered better in their community than in an institutional setting. But as I mentioned before, the jails have become and prisons have become the de facto mental health treatment facilities. And in urban communities in particular, in Detroit, Grand Rapids, when I visit those jails are quite frankly filled with persons of color that have serious mental illness. Now, I'm not saying that there are no Caucasians, but I'm telling you, the vast majority are people of color, and we're not getting them the help. And there are many reasons for that. I participated in an event like this a few months ago that was specifically, again, talking about diversity, equity, inclusion, and what it's like to be African American and live with a disability. And one of the questions that I got during that event was, we were talking about CIT. Trish mentioned earlier, and for those who are not familiar, CIT is Crisis Intervention Team Training, and it's a collaborative between law enforcement and behavioral healthcare organizations when dealing with people who are experiencing behavioral health crisis in the community. So in this conversation, I was asked, how do we prevent law enforcement from hurting and killing people of color who are when they respond to behavioral health crisis? And the numbers are out there. You know, one of the things that we have to do in America, and one of the things that are frustrating to me, and again, I don't mean to offend anybody, is we are in denial about the race issue we have in this country. And the numbers are there. The numbers don't lie. Like I said, the jails are filled with more people of color who have mental illness than not. So my point is this. So when I was asked that question, I said, well, why don't we back upstream and be preventative? Because I'm all about prevention. Most people call law enforcement when a person is experiencing behavioral health crisis, really when it becomes a crisis, when we're scared. People call the police. You know, my wife would call the police, and I'll use myself as an example. If Kevin's off his medication and he's acting out and he's walking around the house with a knife threatening to kill me, that's when people pick up the phone and call the police. Why don't we get people help at the onset of their mental illness and never let it rise to the level that we have to involve law enforcement? I am a huge supporter of crisis intervention team training. Actually, full disclosure, I sit on their board of directors, and I do that because I believe so much in the program, but also I believe, and I'm saying this as an African American man, I believe that most law enforcement officers are trying to get it right. We have bad cops, like we have a few bad plumbers, and we have a few bad, I can't get the people to pick my garbage up. And I've been living here for 11 years. Most law enforcement officers, and I have the privilege of training them, so I get to see them up close and personal. Most of them are trying to get it right, but they don't have the training that they need. They don't have the resources that they need. Most law enforcement officers aren't aware of the resources that are available to them. But what I say to those families and to every family is stop waiting until I'm out of control when you're forced to call the police. Help me when you first see it coming. Help me when you know I'm in trouble. Don't wait until you have to call the police. That helps that's a better outcome for everybody involved. So anyway, we can go to the next slide. Despite recent efforts to improve behavioral health care services for African Americans and other minority groups, there's still many barriers that remain regardless of access and quality of care. That comes back to stigma, always my number one. I mentioned before, distrust in the healthcare system, and that's something that we have to get better at in communities of color. We have to trust the science and go get the help that we need, whether it's for behavioral health related issues or other medical related issues. Lack of providers from diverse racial and ethnic backgrounds. I said before, I think it's great. We know that there's a tremendous shortage in Michigan and nationally of behavioral health care professionals, be they social workers, psychiatrists, psychologists, peer supports, what have you. But we need to encourage more people, period, to seek, to pursue this as a profession, and especially in communities of color. People like to be treated by people who look like them. One of the things that I've learned since I've been, or I should say validated since I've been in this role, is veterans like to listen to veterans. Veterans don't want to hear from me if I never served. Cops want to listen to cops. Kids want to hear from kids. They don't want to hear from old people. And people, male, female, Hispanic, Caucasian, African American, they feel more comfortable receiving treatment from people who look like them. That's just the way it is. And so we need to get there. I talked about lack of culturally competent providers. This is yes, it's a real problem, but this is I think, a willingness and a training issue. I think we have to be willing to understand, I with my wife and my daughter, I know women see the world through a lens that's different than the way I see the world. When my wife tells me about something, I'm a man, and men, we're programmed, and we're in what I call the most help needed group. So whether you are Caucasian, Black, Hispanic, us men need some help. But we listen to fix things because our culture tells us we're supposed to be protectors and providers. So when my wife tells me that, and I'm trying to get better at it, when she talks to me about stuff, I literally ask myself 1,000 times while she's talking, are you telling me this just because you want to vent, or you just want me to listen, or do you want me to provide you with a solution? And I always try to stop at number 3 and keep my big mouth shut until she gives me an indicator. The same thing I think in providing culturally competent care. I think we have to admit and accept that there's a difference in cultures and community, and be willing to embrace that and be willing to receive training, whether it's DEI training or whatever other specific training is out there, to say, you know what? I recognize that people in the Arab American community see the world through this lens, and I need to address it that way. People in the Caucasian community see it this way, people in the African American community, and we have to be willing to address that. Or again, we just turn people off and they don't stick with their treatment plan. The last one is lack of insurance or underinsurance, and CCBHC and a number of other programs help us address that. So we can go to the next slide. I'm not going to dwell on this much. This is a slide, it's information from a workforce site that I visited that said, 76% of ethnic minority employers report employees report experiencing at least one unwanted race-based behavior from a colleague within the last 2-year period. I have one of my NAMI presidents was telling me she was in the car. She's African American. She had her hair braided, and you know where this is going. She's in the car with a couple other Caucasians driving to a conference, and one lady just got stuck on her hair. And can I touch your hair? And can I do this? No, that's a sensitive topic. That's a culturally sensitive topic. And she said, I wouldn't have ridden with you if I knew the topic of conversation was going to be my skin and my hair. Discrimination results in higher levels of stress, depression, anxiety, and negative emotions, which negatively impact productivity and overall life satisfaction. Many minorities face unique cultural stigma and language barriers that prevent discussion and help seeking. I saw an interview with a young lady who her name is Muslim or appears to be African. And she said that she had gone on a number of interviews and couldn't get hired because of her name, they thought she wouldn't be able to speak English well. So that's one of those barriers that we face. Different communities experience mental health symptoms differently, resulting in misdiagnosis and lack, again, of culturally sensitive care. That's just something that I think we have to learn, and that we cannot continue to ignore and think that it's not real. And it's real for everybody. We can go to the next slide, please. We talked a little bit about the LGBTQ community. Again, I'm a heterosexual male, but I am not in the judging business. 75% report experiencing mental health challenges because of work. 37% have experienced workplace harassment. And as we mentioned in the previous slide, discrimination results in lower job satisfaction, higher absenteeism, and attrition. People need to feel comfortable where they are. People need to feel accepted where they are and where they work. And being able to work, being able to provide for yourself and your family, that affects our behavioral health. When I lost my job and couldn't take care of my family the way I thought I should be able to, was I depressed? Absolutely. Absolutely. We can go to the next. And that doesn't discriminate either, not only by race, but by male versus female, because we know we know that there's discrimination in the workplace, whether it's wage disparity, comments being made, all of those other things. People need to feel comfortable in their workplace. I'm sorry, we can go on. Other common barriers include the importance of family and privacy. I talked before about, parents and people in our families, they don't want anybody to know that a family member, and again, this is regardless, stigma varies in community, but we know we don't want our friends, neighbors, people we worship with, people we work with to know that there are mental health problems in our families. Concerns about stigma, medication, not receiving appropriate information about services, and dehumanizing services have also been reported to hinder African Americans and other communities of color in accessing mental health services. I love this picture. I found it a couple years ago, and I was doing a presentation for a faith-based organization, and we talked in depth about this issue of praying mental health issues away. I believe in the power of prayer. I said that before, but I believe in prayer plus. We can go to the next, Trish. And we're almost there. So what do? We stop racism, stop stigma. It's that simple. Stigma and judgment prevent African Americans and other groups from seeking treatment for their mental illnesses. Research indicates that Blacks and African Americans believe that mild depression and anxiety would be considered crazy in social circles. Furthermore, many believe that the discussion about mental illness would not be appropriate even among family. We need to be discussing our behavioral health at the breakfast table and the dinner table, just as we talk about diabetes and cancer and exercising properly and all of those other things. And again, that applies to every community. We can go to the next. We're almost home, folks. So what do? Again, we need to educate. I believe in education. I believe in people making educated decisions. Don't let Facebook and TikTok be your source of news and help you make what could be life-threatening decisions. I saw a meme on Facebook a couple of days ago, and it was addressing the COVID vaccine, and it said, Santa Claus has been watching us all, and we're all getting science books this year for Christmas. So we have to become more educated. We have to encourage everyone, and specifically and people of color, to pursue behavioral health care careers. If we're going to complain about not having access to culturally competent care, and if we're going to complain about how we're treated, then we have to be a part of the solution. And part of the solution, and I'll use an old analogy as a kid growing up, when I went out to Belle Isle to play basketball, or if I went over wherever I was, your opinion didn't count while you were sitting on the sideline. Your opinion about the game only counted if you were in the game. So if we want to change the game, you have to get in the game. You can't just stand on the sideline and continue to complain. And in saying that, we have to become advocates. We have to become advocates for ourselves and for our families. We need to not be afraid to talk about behavioral health care concerns. The family that I was with in Portland yesterday did not know that literally a family 200 yards up the street, if that far, had also lost their son to suicide. They said they've been neighbors for years. The family that had previously lost their son never talked about it, didn't want anybody to know. It took the family that I was with, they held a fundraising event in memory of the son that they lost. And that's what made the neighbor come across the street and say, oh, I lost my son too. So we have to be advocates, and the best way to advocate is to normalize the conversation in every setting. We should be talking about our behavioral health care. And then I mentioned before, when all people, to Lois's point, when all people are ready to receive behavioral health care, we must be there, ready to provide treatment with dignity and respect. We can go to the next. Jessica, I see your question. We're going to get to it. I'm wrapping up. Here's the thing that we know, and this is the thing that always brings me hope. Despite all the barriers we face, we know that every year people overcome the challenges of mental illness to do the things that they enjoy. And that's got to be our message. We know that early intervention leads to better outcomes. And we do that by normalizing the conversation. And to Jessica's question, how do you start the conversation? Be willing to tell people your story. Start there. Lois mentioned that early in her life, she wasn't comfortable talking about what she was experiencing. But now it appears that she's more comfortable. I never knew. I was so afraid when Dominique was going on this journey. I was so afraid to lose him that I didn't think about stigma. And I knew then, and I still know now, there are members, my siblings are still really uncomfortable hearing me say, you know what, I planned my own suicide. There's still people in my family who are uncomfortable knowing that Dominique lived with a mental illness. And there are friends and family that I have who are uncomfortable with my outspokenness as an advocate. And they're going to have to get over it, because this is where I am. And I truly believe that you can only help people if we start the conversation. We can go to the next slide. I think that's the last, gets to some resources, and then we can take a few more questions. And then the last one, if you just want to leave it up, is my contact information if anybody wants to contact me. So I think I'm going to try to pop over to the chat. I saw one question. Are there any other questions or anything that I missed, Trish?
No, not any questions that I saw other than Jessica asking for tips on the conversation. Just some, chat back and forth, but I think now we can open it up if anybody does have any questions. I'm going to stop sharing so now we can see people if they want to come on camera. And I want to thank you, Kevin. Obviously, OCHN has a, I want to say big push, but, values diversity, equity, and inclusion. We've been working on this for the past few years. We have, a detailed work plan, and we will be, increasing those efforts, those trainings. We've had multiple trainings throughout for our providers as we look to tackle those health disparities that we see. So I'm going to open it up to see if anybody has any questions, comments. Feel free to unmute yourself or put it into the chat.
Kevin, I just wanted to expand a little bit on my question. I personally feel very comfortable, talking about mental health, telling people about my experiences with my mental illness. But I know, as you made it clear during this presentation that not everyone feels comfortable having those conversations. So I guess my question would be, how do you approach conversations with people who just don't want to talk about it? Do you have any advice for that?
You know, for me, Jessica, and I'm still getting comfortable with this because I always talk to Christine and Dana and other folks that I work at OCHN, and I don't take myself very seriously. So I'll say things like, I don't know why anybody listens to me anyway. But the response that I've received, honestly, and again, I say this with humility because I really have no ego about this, is people say it is the way that I deliver it with passion and transparency that encourages other people to either listen or share. And so I don't think we can push it on people. I think it's just like receiving care. We have to be there when people are ready and willing to talk. But I don't want to beat them over the head with it because I don't want to scare them off and run them away. But I just think the more we talk about it, the more comfortable people will be. I have to thank again OCHN for support. I know a number of you are familiar. My wife and I launched a brand, Everybody versus Stigma, earlier this year. And I did that because I wanted to be able to start the conversation with people. And so one of the things that I've done, and maybe some of you have already experienced this, I had to apologize. The very first time I wore my t-shirt to a Meijer store out here in Plymouth, I'm sorry, it's in Canton. I literally had to apologize to two cashiers because I wore the shirt to Meijer, and I did it purposely early on a Saturday morning just to see if I would get a reaction. And one lady stopped me, and the first question, which always catches me off guard, people said, well, what is stigma? Not what's mental health stigma, but what is stigma? So, I was explaining to her that, it's making people feel ashamed or less than and all that. But then I turned around so she could see the logo on the back that said recovery is possible. And then it let people know that we're talking about behavioral health care concerns. Anyway, when I said mental illness, another lady who just happened to be walking by stopped and she said, what about mental illness? So she joined in the conversation. And then somebody else heard me mention suicide, being a suicide prevention advocate. So they stopped. In about 2 minutes, I had 15 people around me, and we're literally we're doing what we're doing right now, talking about mental illness and suicide prevention. And it didn't dawn on me. I look up and I was like, we're blocking 2 lanes. And so I apologized to the cashier. I was like, oh my God, I'm so sorry. And then she said, well, what are you guys talking about? And then she joined in the conversation. So it's all about whatever we can do to get the conversation started. And then everybody, whether I'm in the airport, people start saying, oh yeah, I know someone, or this happened in my family. So it's all about just getting the conversation started.
I agree. Thank you, Kevin. I'm going to put in the link for everyone. I have somebody asking for it in there. I have a t-shirt, but I feel like I'm going to need a sweatshirt now. It's getting cold.
Yeah, we're getting into hoodie season, so. Any other questions? I want to be respectful of your time. I'm actually impressed that I haven't gone over yet. So, because I will talk about this.
You knew I added in extra time, Kevin. So, we had a really good turnout. So I thank you for that. I think at one point I seen we had over 70 people. Again, obviously a great topic for us, wanting to highlight World Mental Health Day that was on Sunday. But then also looking at the topic of mental health in an unequal world, and really looking at, the equity of it. So again, I thank you so much. I love every time I hear you speak. But we have about 9 minutes left. So anybody has questions? If not, I'll end our recording, and then Kevin, we can stay on for a couple minutes and see if anybody has any other questions or anything like that.
And before people start signing off en masse, I sincerely want to thank you for the time, your presence, participation, and the opportunity. You could be doing anything else on your lunch break, and so I really appreciate you. Please don't hesitate to reach out to me anytime, any questions, any way that I can be of help. Please don't hesitate. And thank you for all you have done and will continue to do, because we're all advocates. And so thank you so much.